And she's a pediatric hematologist and oncologist, and her research focuses on educational outcomes of children with sickle cell disease and children with brain tumors. She has a methodologic focus on implementation science, so I know that's of interest to many of us to talk about and think about. And she's received a lot of funding from different foundations and NIH and HRSA, et cetera, et cetera, et cetera. And really is more on the intervention side, I think, than a lot of us are here at CHEAR. So I thought it would be really interesting to hear from her. On a personal note, Allison is a very good friend and collaborator and mentor and sponsor. And it is my life goal for her to move here and never leave. I don't flight, so she has to stay forever. And so I'm very glad that she's here at Michigan for the first time. And thanks for joining us.
Thank you. I'd like to thank Dr. Reeves for that warm welcome, and Dr. Chua and the leaders at CHEAR for this invitation. It's really an honor to speak here at the Susan B. Meister Child Health Evaluation and Research Center. Dr. Meister's vision for rigorous, policy relevant, and actionable research in children's health services has shaped so much of how many of us think about linking evidence to impact. And that's really been the goal of my work, and hopefully I'll be able to demonstrate that to you today as we walk through the case for sickle cell disease. Right. Let me just use the button. Okay. Oops. I'm good now, sorry. These are my conflicts of interest. And this is just an overview of what we'll go through today. I'll present a case of an actual patient of mine, of course, with the name changed, provide a brief overview of sickle cell disease for the non-hematologists, review some of the key trials that have built our evidence-based guidelines and influence what we're doing in the clinic every day to improve these kids' lives, walk through what we know about cognitive and educational outcomes for this population, discuss what we can do to support these students, and then for something that's a little different spin on most of our work is pulling in the perspective of the students and the school personnel themselves, and wrap up thinking about future directions. So Garrett's an actual patient of mine that I take care of in clinic, and when he was 9, he presented, well, you're born with hemoglobin SS, which is sickle cell anemia, the most severe type of sickle cell disease. But when he was 9, he came to clinic for one of his Q3 month visits. He had a new complaint from his mother, mostly, that school was reporting that he'd changed his performance. So he'd typically been an average student, but had declined some in math and literacy. He'd been taking hydroxyurea, which is one of the few disease modifiers that we have. It's an oral medication that increases your hemoglobin, increases fetal hemoglobin, which is a better kind than the sickling, and his MCV was 105. So usually if it's above 100, we think that people are taking this on a fairly regular basis. He'd been hospitalized twice in the past year, which is about average, had never had a history of overt stroke, and he was having his annual TCD screenings, that transcranial Doppler and ultrasound of your middle cerebral artery that identifies an increased risk for stroke. That had been normal. So we'll keep that case in mind and revisit it at the end to thread the needle of what the evidence shows of what we should be doing for Garrett. But before we go through all that, I just wanted to, like I said, provide a brief overview of sickle cell disease for those of you who aren't as familiar with the condition. So it's one of the most common inherited conditions that we screen for with newborn screening. It's autosomal recessive, and it's caused by a point mutation. So what happens is there's a single base substitution and glutamic acid becomes valine. And as a result, instead of having the normal hemoglobin production, which is on your lower left, you start to have this deoxygenated hemoglobin, and the cells change into a sickled shape that's kind of crunchy. It breaks down in 2 to 3 weeks as opposed to 3 to 4 months. The hallmark of the condition is anemia, different degrees for the different types of sickle cell that people have. It's caused by that abnormal hemoglobin, so you have one S trait and then another hemoglobinopathy abnormality. So it could be another S, it could be from a thalassemia or a C. If we took you in the back of clinic and looked at it underneath the microscope, you would see the image on the upper right with those sickled cells among some other abnormal red cells. And we think that it continues, or it persisted because of the trait being protective against malaria. So I don't want to give anyone any heart palpitations if you're going back to physiology in your younger years, but I just wanted to review the production of hemoglobin because it becomes relevant as we talk about some of these therapies. So on this figure, it demonstrates how the two different chains of hemoglobin are produced, alpha and beta chains, which are the mature types of hemoglobin that we typically see. And on the left-hand side of the figure, that represents hemoglobin production in utero. So while the baby is still a fetus and is inside the mother, there's alpha chains that are always going to be there. Beta chains are happening at a low level along the bottom figure. And then the curve that's red that starts out high and starts to drop is represented as gamma chains, which creates fetal hemoglobin. So while you're still in utero, you're making a lot of fetal hemoglobin, and then at birth, that switches off, and then the beta chains kick up. So we'll just keep that in mind as we think about hydroxyurea because that targets increasing fetal hemoglobin. So globally, this is actually a fairly prevalent condition, and it's mostly a burden in sub-Saharan Africa. So in this map that tries to represent the incidence of babies being born each year, we think over 300,000 babies are born. But since most of these countries in Africa don't have newborn screening like we do in the US, these are just estimates. So you can see the darker the color of the country, the higher the burden of sickle cell. And most people appreciate that sub-Saharan Africa has quite a bit of sickle cell, but you may not know that India actually is probably the second highest concentration, and then areas like Brazil and South America. So anywhere where there used to be a high prevalence, or still is, of malaria tends to be the highest concentration of sickle cell. Now, in the US, this is considered a rare condition, and we think about 100,000 people have this condition. People like Dr. Reeves are contributing data that are probably updating this map. This was published in 2010, and at the time, we estimated that about 100,000 people have sickle cell. The darker the red represents the higher concentration of states with sickle cell. And you can see that California, Texas, Florida, and New York have the highest concentration. Michigan is kind of on the mid to upper level, and Missouri, where I am, is kind of like in the mid-lower area, but we'll say more mid-range, because in St. Louis, we have about 2/3 of the cases in the state. So I described in that earlier slide that this impacts the creation of blood cells, or hemoglobin. And because blood goes everywhere, every organ system is impacted by sickle cell. So just going from head to toe, I just wanted to highlight some of the complications that are more common. So at WashU, we have a long history of studying the brain and the risk of stroke. It's the #1 reason an African-American child would have a stroke. You can have an overt stroke, the kind where you see when someone can't speak or can't move their arms or legs. More common is what we call a silent cerebral infarct, where if you did an MRI of the brain, you would see areas of ischemia, but they're typically in non-motor areas. So that's where the changes with cognition tend to happen, because it's infarction in the frontal and temporal lobes, most common. Going down, you can have pulmonary hypertension, which can be life-threatening. It's more of a problem in the adult age range. If you have the sickling or vaso-occlusion in the lung, you can have something called acute chest. And so for those of you in pediatrics, we're turning to our ICU colleagues often, excuse me, because you can end up intubated in severe cases. You need to exchange the blood to try to push those sickled cells through. And like I said, it's life-threatening. For anybody in renal, these kids go into chronic kidney disease at an early age. They're developing proteinuria. They have avascular necrosis at a very young age. We have kids as young as 14 having joint replacements because you have areas of ischemia in the long bones, and you can have shoulder and hip replacements. For males, they're at risk for priapism, so the tiny blood vessels in the penis can get occluded, and it results in painful, prolonged, and unwanted erections that even with one episode that is unable to be addressed can lead to erectile dysfunction. The hallmark, in addition to anemia, is pain. So we think that part of this is caused by vaso-occlusion, although there are researchers who are demonstrating that that's a much more complex pathway that can occur. And then in rare cases, if you have a hyperhemolytic state, then less than 5% of people will have leg ulcers that are similar to what you think of adults with uncontrolled diabetes. So it's very complex, and within pediatrics, probably every specialty will be involved at some point in taking care of these kids. So now that we have an overview of the disease, I want to walk through some of the trials that have been hallmarks for making advances and influencing our evidence-based guidelines. So within CHEAR, my guess is you guys have looked at data quite a bit, looking at the rate of TCD screening. It's one of the main quality measures that occurs. And this evolved based on the STOP trial. So there's a neurologist named Bob Adams who really advanced this field. And there were many studies that he did. He started by demonstrating that if you do this ultrasound of the middle cerebral artery and it's elevated, like at 200 centimeters per second or higher, those kids with sickle cell anemia, SS or S-beta thal null, are at very high risk for stroke. And then he initiated the trials that led to STOP, where they took those kids with elevated TCDs and randomized to chronic transfusion. So you would drop the percent S from, say, 90% to less than 30, so that you're transfusing healthy A cells compared to observation. And you can see that it reduced the risk of stroke by 92%. So in this figure on the lower left, it's a Kaplan-Meier curve, and it demonstrates on the y-axis the probability of remaining stroke-free, x-axis with the number of months on transfusion. And you can see that up to 24 months, those kids who are on transfusion had no episodes of stroke, whereas each hash mark on the lower curve were those who are on observation. So this is probably what most clinics are focused on, in addition to hydroxyurea as main quality metrics. So being chronically transfused also presents risks and complications. So one, although our blood supply is quite safe, you could get a viral infection as a result of blood. If you have a central line, you could be at risk for infections from being accessed. It also puts you at higher risk for clots if you have a central line. And it's frankly inconvenient for families. You're coming to the clinic every 4, 5, 6 weeks for regular transfusion. So again, just think about the days missed from school, from work for parents. So this is a big deal. So Russell Ware, who's at Cincinnati Children's now, has made his most of his research portfolio focused on hydroxyurea and the role of integrating that to improve care. And so what he demonstrated in the TWITCH trial is that for kids who don't have vasculopathy, so they had an abnormal TCD, but they don't have these abnormal blood vessels that can be identified, if they were transfused for a year, remain stable, you can gradually, over about 6 months, transition those kids to oral hydroxyurea and help them remain at lower risk for having a stroke. So this was a big change because this allows kids to do more of this from home and not have to come into clinic. So in addition to the screening, transfusing, now we have the option, if we feel like the families are adherent, they could switch over to hydroxyurea. Another game-changing trial that was done for hydroxyurea was led by Win Wong, who passed away late last year. He was at St. Jude, and he ran a study called Baby Hug. And this was really a practice-shifting trial because the way we started using Hydrea was in an adult trial, the MSH trial in the 90s, that showed if we took high-risk adults, so having more than 3 episodes of pain and acute chest, you could give them Hydrea and decrease those complications. Whereas Baby Hug was shifting this to a prophylactic approach. So what the teams did is they approached kids 9 months and older with sickle cell anemia, 9 to 18 months, and randomized to giving Hydrea versus close observation. And what you can see in these curves is the quarters are acute chest pain, dactylitis, which is how infants and toddlers present with vaso-occlusion. Their hands and feet get puffy and swollen and painful. And then the risk of transfusions. So the blue curves are those complications in the observation arm. The red are the infants and toddlers who were on Hydrea. So all of those were significantly lower in the intervention arm. So now that our evidence-based guidelines tell us that we should be suggesting hydroxyurea starting at 9 months of age. So I've been doing this long enough that when I was practicing in the late 90s, early 2000s in my training, the patients I saw had many, many more complications, and our inpatient census was much higher than it is today. The phenotype of a child who starts hydroxyurea early is much different in a much better way as a result of this. So this was a big deal. Another trial that shifted quite a bit was run by Mike DeBon, and this is the SIT trial, or silent infarct transfusion trial. And it was a similar style trial to STOP, but what it did is it took kids who had had between 5 and 15 with sickle cell anemia, had had a screening MRI, identified those who had silent stroke. So you saw the infarction, but no neurologic overt finding that paired with that lesion, and randomized to blood transfusion versus observation. And again, the goal was to decrease the percent S down to less than 30%. So at the end of 3 years, what it showed is that those who were on transfusion had a 60% reduction in recurrent stroke or TIA. And then for those kids who screened negative, we were doing cognitive assessments, and then we did them on the kids who had infarcts as well. And we showed that those with silent infarcts had IQs that were about 5 points less than the other group. And just as a reminder, average IQ is 100, a standard deviation is 15. So this is a third of a standard deviation, which is a significant clinical and statistic drop. I briefly want to mention L-glutamine, but if you've looked at the data from SCDC, you probably know that this doesn't have a high uptake. It's very benign. It's an amino acid that you can take, but it's kind of this gritty powder that you mix with water. You take it twice a day. We have very few patients on this, but the trial that advanced that for approval in '97 showed that it reduced the pain episodes by about 1 a year. The big shifts that advanced for CHEAR, transformative therapy, are stem cell transplant. So this has been happening from trials starting way back in like 1996. If you have a matched sibling donor, the chance that you're going to do well with an event-free survival, with very few complications, is about 95 to 96% if you have an HLA matched SIB. If you have an unrelated donor or a family member that's not a perfect match, it's more complicated because you can have graft versus host disease. But in an experienced center that does a lot of these, you still probably have an event-free survival in the high 80s. But this is a meta-analysis of almost 1,800 patients, many of whom had HLA-SIB matches. And so what it's showing you on the summary on the left-hand side is that for most organ systems, you stabilize organ function. So your lung function seems to stabilize, your cardiac function does, your cerebral blood flow improves because you're at a higher hemoglobin. The thing that takes a bump for the worst is renal, and it's probably due to the prep with the chemo. So unfortunately, just like anybody else who gets a stem cell transplant, it does hit your kidneys with all the high doses. So the focus of this is not gene therapy, but I can't get through a talk without talking about this. So a couple years, gene therapy received FDA approval, and this will probably be one of the other big shifts if we look back 10 years from now. So there are 2 different types of gene therapy. One is using a lentivirus transduction. And so you can use this is just a high summary. So if anybody out there who's a researcher for this, I'm not going into all the details, but in the simplest way to summarize that, you can use a virus to introduce the ability to start making either healthy beta globin genes, remember that figure at the beginning, and so that would create a type of an A hemoglobin or anti-sickling, or you can disrupt BCL11A, which is a gene that is like a switch for that fetal hemoglobin. So you can either increase the type A for some brands, or you can increase fetal hemoglobin. So that's one of the brands that got approval. The other is with CRISPR, which is a type of gene editing. So with this, you have like an imaginary scissors that cuts the DNA, and then you can join things together so that you're going to induce fetal hemoglobin. So that's the other brand that was approved. There are other trials that are going on that try this homology-directed repair. It's a more complex thing. It's not commercially approved yet. But this was groundbreaking, and this means you're your own stem cell donor. So if you don't have a matched sibling, you can mobilize your own stem cells. They get manipulated in a lab. You get it back after, similar to an autologous stem cell transplant after chemo. The next two slides are just showing you the outcomes from those two products that either create beta or fetal hemoglobin. The purpose of this is just to show you that each row is a participant in the trial who had the gene therapy. On the left-hand side, all those little red dots are the people's painful episodes in the year before the therapy. And on the right, you see very few dots, if any. So this was transformative for them. And it was approved based on reduction of pain. And then the other brand that induces fetal hemoglobin, similar trend for the outcomes. So of note, for those of you who are interested in comparative effectiveness research, it's not lost on us that the cost of gene therapy is $2 to $3 million. So it's not a simple investment, but there have been models that have been conducted that show that it would be worth it in the end when you start thinking about QALYs. But common themes for any of these disease modifications are that we're trying to reduce these complications that are listed. But yeah, we always have these gaps when we're looking at the data of what's recommended versus what's happening. And so I think part of it has to cause us to reflect, like, how are we framing this so that we're trying to get families to get on the same page as us and take the recommendations. All right, so why is Allison focused so much on education when she's a hematologist? That's a good question. And it started back when I was a fellow and I was seeing these kids in clinic. And I went to my mentor and I said, he was running the CHEAR trial. And I said, Michael, everyone's talking about the silent strokes, but I have a ton of kids who have normal MRIs and they're not doing well in school. So that just started me on a 20+ year trajectory. So we and others have described that these kids are at increased risk for grade failure, repeating a grade. So over 60% of kids who have a silent stroke will repeat a grade. This is most important if it occurs later in your educational experience. So if you start failing in middle school and high school, you're much more likely to drop out, and therefore they have lower rates of high school graduation. And so we all know, if you're thinking about your own kids, you want them to do well in school because the further you get in education, the more choices they seem to have for life opportunities and higher earning potentials. So, I spend a lot of time talking about this in the clinic as well, and just trying to emphasize it's important that you have choices. And so my goal is to help maximize their ability from a medical standpoint and others so that they can participate as much as possible in school. So I mentioned the CIT trial that Mike DeBon ran. So I had the opportunity to design some ancillary studies for that. And I inserted questions that dealt with looking at risk for grade retention. So silent infarcts are important. I told you it lowers your IQ. They're associated with cognitive changes. But when we look at a macro measure like grade failure, it didn't enter the model. What did, though, is income per capita. And so to no one's surprise, but I had to demonstrate it with data, the more poor you are, the higher risk you are for grade failure. And so these data were collected in 2005 to 2008. So you can take the numbers with a grain of salt. But basically, a family of 4 was just above poverty. At that time, poverty was $22,000 a year. And on average, our patients had an average of like $24,000 for a family of 4. So if you had less than $3,000 per person per year, you were 6 times more likely to fail a grade. Obviously, the more years you've had in the educational system, the increased risk for grade failure, and then consistent with the general population, males were twice as likely to fail than females. We also had the ancillary study looking at IQ. And so what you can see from this figure, because we tested those who screened negative for MRI and then the kids who participated in CIT, was a general decline with age. So on the y-axis, you see the predicted IQ score. On the x-axis, you see the age of the kids, 5 to 15 years of age. And the first thing that should strike you is it's a negative slope. So for each year that somebody ages, the risk is that your IQ is going down. Your best case scenario is that the MRI was clean and your caregiver had some amount of college education or higher. Interestingly, in the middle, you could have an infarct, but have a caregiver who had more education, and you were predicted to have a higher IQ than someone with no infarct, but a caregiver with lower levels of education. And so that's really getting at the family environment, like what's happening in the home. You know, we did other interventions in the past where we did this assessment called the home, where you tally up how many books and opportunities to learn are in the house, and it makes a difference. We've showed it in young kids that if you intervene, you can improve their cognition. So using some data that were related to SCDC in Missouri, as well as our Implementation Science Consortium, we obtained Medicaid data over 7 years and paired it with our Department of Education data. We chose to look at the achievement tests in the 8th grade, again, because of that pivotal moment of transitioning to high school. And we looked at our standard scores for math, science, and communication arts. So you can see in this summary that the kids with sickle cell disease who are in public schools on Medicaid have a much lower proficiency rate than their comparison students who are in the same zip codes, same school districts, but no chronic disease. And if you're wondering how Missouri does in general, if I had another column, our proficiency rate is probably among the high 40s across the board. So these are more impoverished kids because they're all on Medicaid. And by full admission, our state could be doing better. We're working on it. Okay. So why does this happen? So we have the medical issues. Cognitive deficits are common among this population. It's very common if you've had a cerebral infarct. But like I said, you could have these deficits even without an infarct. We think it might be due to the chronic anemia and a predisposition for areas that are at higher risk with higher blood flow. But again, we have to consider the environmental issues. So the most common deficits that we see are with executive function. So the kids could be impulsive, have a hard time staying on task, paying attention, working memory. They have slower processing speed, and it's most evident in my young adult clinic. If I'm talking and I ask a question, I could count to 1001, 1002 in a lot of cases before I get the reply. So I'm sensitive to this fact, but if you don't know it, you might think that the person is trying to be obstinate or having a problem. And then most of the kids aren't aware that they have these deficits, so it makes it very hard to introduce any type of remedial intervention. And it's very hard if you're a teacher and you don't even know the student has sickle cell, much less they have these cognitive deficits. And so what happens is some of our kids get labeled as problematic, like they're not listening, or they don't want to pay attention, or if they're impulsive on the school bus, they're labeled as a troublemaker. And a lot of it is because they have these cognitive challenges. So what else is associated with this? So I've shown you data. We and others have demonstrated that increasing age causes problems where things get worse. We've shown in the US and in Nigeria that the higher the TCD, the worse these cognitive outcomes are, particularly executive function. And then on the right, these are the issues that we see in the general population. If there's economic deprivation, you tend to have lower literacy skills, verbal skills, worse executive function. And Andrea Ford, who is an adult neurologist at our institution, published a nice paper earlier this year that demonstrated that among adults, there's a larger brain age gap among people with sickle cell compared to controls, particularly when you factor in economic deprivation. So depression is more common in both our patients as well as the parents. And as you can imagine, when a mom is depressed, they have worse executive function. So you're just trying to get through the day, right? So if your goal is just to get through the day, keep your kid in school or out of the hospital, it's much more challenging to think proactively and organize your home and impact learning. And then just like the general population, if the caregiver has less education, that is also related. Yes.
Question about brain crack. Is that really, I mean, you're essentially looking at probably MRI scans and comparing them to sort of a normative group in terms of, okay, you're X age, this is where your brain structure is supposed to look like. And the gap between what you expect and what you observe is higher in patients that have sickle cell?
And economic deprivation. The question was, well, I don't know if people online can hear this or not, but the question was about the economic deprivation issue. So on the scans, there's less brain volume in the patients with sickle cell, and it's exacerbated by lower socioeconomics.
How many group does not have sickle cell?
Right, right. But you can see in the normative group who have lower SES that they start to trend towards that as well. So it's just like having a compounded problem with both the disease and lower SES. So I always present data with IQ because that's the easiest measure to get. And when NIH cut funding for SIT, our cognitive profile was cut to IQ in the brief. But clinically, what's most important is getting these domain-specific assessments because you need to know specifically where the challenges are in order to develop changes in the way that you instruct somebody. So if someone lacks executive function, you need to provide cues for organization. The example I always give is like my son got assigned a 5-page paper. You're not going to give the assignment on Monday and come back the next Monday and collect it. You're going to give the assignment on Monday and then on Tuesday request the first 3 paragraphs. And on Wednesday, you're going to request the first 3 pages. And on Friday, you're going to request the whole thing to give feedback, the weekend to revise, and then turn it in on Monday. Most people do better when you break these things into chunks. It's better for me, and I haven't been diagnosed with anything, but it's definitely true for people who have executive dysfunction. And routine is that person's best friend. Give them Groundhog Day. Make them do the same thing every day so that they start to become trained on how to approach the organization. If you have slower processing speed, giving notes or recordings is extremely helpful. Extending the test time doesn't cost anything, and that's a common accommodation. And then for attention, it's just like anybody with ADHD. Try to put them in an area of the room where there's fewer distractions, and if it's relevant, you can offer medications. So Ebony Lance, who's an investigator at Kennedy Krieger, has published nice work that demonstrates that despite demonstrating that these kids have attention deficits, the rate of prescription for Ritalin is much lower than what you would expect. But that's a whole nother topic. So let's say that students in the public school system, what should we be doing? Well, whether you're in public or private, we've adopted the approach of doing educational inventories in clinics. So our EPIC notes are just pre-populated for us to ask people, how's school going? Any change in subjects or grade level? If anything's endorsed, then we move forward with doing the screening MRI and a referral to neuropsych. And then we're lucky enough to have an educational liaison in our clinic so that she interacts with the school systems and helps advocate. If they're in a public school system, they should all have a 504. It doesn't cost anything. It's like the equivalent of the American with Disabilities Act, but for students. And so the other thing about their kidneys that I didn't mention is that kids with sickle cell will hyperfiltrate. So they're going to make more urine than the average student. So they need to drink more water. So they don't need to be harassed by the teacher or anybody else around because they need more water in their water bottle. They have to go to the bathroom more frequently. It's a frequent complaint that we get. And then you can share things like a pain plan similar to an action plan with the school nurse. And then if the educational challenges are more significant and special education needs to come into play, then they can have an IEP, and that will modify the way of instruction. So the other thing that should be considered is as these kids age to be teenagers, by law, when you're 16, you have to start addressing transition. And so we encourage those schools, if somebody is having more academic challenges, to think about a vocational education track so that they have trained skills and still keep their earning potential up. Okay, so this is where I admit I had really good intentions when I was younger. I still do, but I had a lot of enthusiasm, but I really hadn't thought it through. So all these are the titles of papers that I had written in fellowship and instructor level. And I demonstrated that there's a gap in knowledge, that we weren't identifying these kids, and I was all enthusiastic. I went to the St. Louis Public Schools, provided education to teachers, did pre-post assessments, everyone learned, and then it fizzled out. So I was thinking, gosh, I'm so willing to do this. Why don't people want this? famous last words. So, you know, I wasn't considering what they wanted or needed, but I still continued in this vein, and this will come back as a thread. So our clinic, though, has adopted this as a priority. So every one of our patients has this letter that gets sent to their school. We give it to the parents. It gives an overview, and part of it is a table with common complications. And, you know, that has worked out pretty well. So in addition to the case that I presented, I wanted to share a success story of a patient that I just saw recently. So when he was 11, he was had SS, and he was diagnosed with a silent cerebral infarct. And so the option was to go on chronic transfusion. We had a long talk about the implications of this. Interestingly, he's one of 14 children. They're all full siblings. It was amazing. So we typed them all, and 2 were exact matches. So he opted to go ahead and get a stem cell transplant, had a great outcome, and he was feeling so good, it inspired him and his family that he decided to leave our public schools in the city, which have had their challenges, and he opted to enroll in a private school in the county. And so tuition is significant, but he got a scholarship. The community worked hard to get him through everything. At entry assessment, he was 3 grades below what he should have been when he did performance tests, but everyone worked well with him. And he excelled. He got a scholarship to university and then went on to get a master's. And I saw him recently in my young adult clinic as like a long-term follow-up, and it turns out he's working in our health system's clinical immunology lab. So it's great. He's thinking about applying to medical school. But when I asked him to reflect back, he said the best thing he did was get that transplant. And then the second best thing he thought was going to shift his opportunity for school, because it made all the difference as far as his next level of options. So again, just driving home that point of trying to intervene from a medical standpoint as well as within the school. So remember how I failed and everybody wasn't getting as excited as I was when I visited the schools? In an effort to remediate that, I just want to show a project that Kelly Harris, who's a mentee of mine, that she and I are wrapping up. But we decided to really try to pull in that perspective of the people from the schools. And I think by now you probably endorse these statements. So in general, the schools aren't aware. It's a rare disease. You might have 1 child with this condition in the whole school. And there's really no easy opportunity for educators to learn about this. And things are very siloed. You know, the hospital and the clinic is over here and the schools are over here, and we're sending a packet. But beyond that, we don't know if it's actually reaching people in all cases. So we wanted to complete a needs assessment in a collaborative way to try to plan an intervention that will have more sustainability and impact. So first we formed the collaborative team and then conducted this. So the next figure is not for you to strain your eyes and see, but this is what I feel like is making the most difference. So is bringing in these frameworks from implementation science. And the easiest way for me to explain this is it really provides us like a blueprint of how to approach things. Just like when you're building a house, you want to check off all the things that you've considered, you know, how the land is graded, the materials, what the family wants the house to look like. So these frameworks are trying to do that for us with interventions. And this is one particular that's focused on community-based participatory research, so bringing in the stakeholders and then planning that implementation. So initially what we did is we worked with leaders from 6 school districts and our CBOs and the head of our state school nursing association, and then we met on a regular basis to work through what their challenges and concerns were. For those of you in public health, I'm throwing in a logic model for you, and then you know, going ahead and conducting that needs assessment. So we've done phase 1 and 2, and we're now entering phase 3. And our survey and focus groups were largely focused on these topics: knowledge and awareness, ability to identify these kids, providing training, guidelines that the schools weren't aware of, and the key priorities of the team. So in order to participate, what we asked is that if you were in these school districts that we had established relationships with and you had anything to do with the students that you participate, we had students themselves. We also had caregivers, but if you were part of outside of those districts, we didn't include people at that time. And these are the main themes that evolved. So it was awareness. So most families weren't actually proactive about sharing about their child. And then even if they did, the schools weren't necessarily so aware of what was going on throughout the building. Communication, knowledge about the disease, what supports could exist to help the educators, training, and then building that trust. And that can be trust from the families to the schools to us. So after those themes were identified, we then formed our key goals and priorities that are listed here that basically align with that. And then again, this is one of those figures that's coming up, not for you to strain your eyes, but just providing some structure of how we're going to approach this. So together, all of us contributed to the inputs of this model, the activities that we would work on, who was going to participate, short-term outcomes, intermediate, and long-term. So we're really in like the short-term outcome phase of this work right now. So after all this was completed, we then summarized it and presented it in survey form because we were local to only 6 districts. And for this, we went across the state, and you can see all the red dots are the people who answered the survey. It was much more diverse. In Missouri, most people with sickle cell live along this Highway 70. So Kansas City is on the westernmost part, and St. Louis is on the easternmost part. And eastern Missouri has 2/3 of the people with sickle cell in the state. So this, you can just see that over 400 people replied. We did have 13 students who replied as well, and some caregivers. And then we presented the findings and asked, like, do you agree that these goals and priorities resonate with you? And overwhelmingly, people endorsed this. The red are the adults, and the green are those students. Students in particular wanted more academic support and care coordination. And then there was a smattering of other that are represented here. So emphasizing that it's not just the primary teacher that needs to know, it's the person who monitors the lunchroom, the recess monitor, you name it. They wanted the entire staff to be aware. They wanted these action plans like we do for asthma. This issue of water really came up a lot, the accommodations, and then resources for families. So these are some of those challenges that we've highlighted before. And again, the biggest challenge that people reported was that jump from middle school to high school, because there was a lack of carryover, because it's usually you're jumping buildings and it's very different. And the lack of formal training is a problem. Resource needs I thought were interesting because parents really wanted a greater opportunity for support groups. We only have a couple school-based clinics in St. Louis, and for those schools that did, they wanted a greater partnership. St. Louis is not incredibly diverse with immigrants, but we do have some people who immigrate from like part of Africa that are French-speaking. They wanted more community events and more standardized professional training that was mandated. So the other thing that came up is in our city school districts, we lack resources. It's all tax-based. And a school nurse is not necessarily in every school. I don't know what it's like here, but when I grew up, each school had a school nurse. So now a nurse may serve, a handful of schools and kind of rotate around, and that makes the students very nervous and the families as well. They also would like people to understand when they're in pain. They just don't, it's like having a migraine. They don't want to be stimulated, and they want a chance to just sit in quiet. And then in the pandemic, we all embraced this idea of doing things online, and then that's kind of started to peter out. So the students really want more of an online option if they don't feel well enough to go to school, but they still want to keep up with the assignments. So obviously you can appreciate that we need these comprehensive and multi-pronged approaches, and we will work on these plans. So in bringing it all together, I just want to come back to these evidence-based guidelines. So all those trials that I walked you through in the beginning inform the evidence-based guidelines that were written by National Heart, Lung, and Blood Institute in 2014 and updated by American Society of Hematology in 2020. But as I always say, guidelines don't implement themselves. We all know, like if you interview providers, we'll always say, we know about that guideline and we do it. But then when you check the data, there's some complication that we're not doing it. And so that's where we hope that implementation science comes in to close that 17-year gap and speed things up. So let's come back to Garrett. So hopefully you've figured out that, you know, there was this complaint. So as a result, we did get an MRI. In fact, he did have a silent infarct. He got the neuropsych eval. We worked with the schools. He started chronic transfusion. And so far, he's doing relatively well. But we did meet with both the family and the school system. And again, like I said, we're lucky we have that school liaison to help. When I was younger, I used to travel to all the schools, and now I'm too busy to get out to all the schools, but Zoom has helped some. But Sonia, who's our educational liaison, is fantastic. So the key word is always systems. I'm sure you guys talk about this a lot. So things that we've done in Missouri, we're lucky enough to be a part of the HRSA collaborative. So we have the state action plan. We have all the leaders from the sickle cell clinics across the state participate with the health systems. We're trying to all work on improving the quality of these types of things, sharing resources so no one has to recreate the wheel. We have some FQHCs who are part of this. The State Association of School Nurses has been a fantastic partner. And of course, our community-based organizations. So we also get to be part of the SCDC. We're a more junior member. We're newer to it, and we're so appreciative of Dr. Reeves' team because they've been mentoring us through this. But when all of our data are together, the goal is then to use that as the surveillance so that we can do quicker checks of, you know, are we really doing what we should be doing? And then geolocate so we can give the feedback to the clinics and hopefully influence policy. So earlier on, we published papers that demonstrated that these kids, over 50% of them will have developmental delay. And so other states have embraced that and influenced policy, like Tennessee. So in Tennessee, if you have sickle cell, you automatically qualify for early intervention. Missouri hasn't done it yet, but we'll keep trying. But hopefully those are things that we would like to influence. And then within our own health system, what we've done is work within the EPIC environment of building a system-wide registry so that we can, within Healthy Planet, track performance as well and hopefully have more efficient ways to implement things there. So hopefully what we're going to do is be able to work on translating that last needs assessment into intervention, collaborate across all these levels of engagement with families, as well as the systems that interact with these families, and implement strategies that will help target them. But whether you're a pediatrician, you're a nurse, you're a researcher, you know, just remember that your knowledge and actions can definitely positively impact the student. So I heard from Sarah that there was a run over the weekend for sickle cell. You know, it's a big deal when our families run into some of us in the community. And I don't always appreciate this, but apparently, you know, our words carry some weight. So the parents are always appreciative if we pay kids a compliment for doing well or paying attention or state, you know, shared goals for them to succeed. It could probably influence more than we really appreciate. And we can advocate for the kids to improve their accommodations and reduce the bias that they face. So ideally, we're all working together, implementing these solutions. And for those of us in the healthcare space, obviously, we want to deliver the quality care that we know should be happening. But the schools need help too, because they probably spend the most of their time, most of the students' time with the educational system. So it's a missed opportunity if we're not reaching out to help them there. And then supporting people in the community to help enrich their environment and help them access support for them and their families. So these are members of our lab and the clinical team, funders, and our local CBO. And I just would like to thank all of them and acknowledge them for helping us do the work over the years. And with that, I would be happy to take questions. Yes.
So I imagine for some schools, it can be very challenging to manage a handful of kids with chronic disease X, and then another, you know, kind of handful with chronic disease X. But then they also have to manage, you know, the specific needs of people with depression, ADHD, and anxiety, and you know and I just wonder how much some of the gap that, in terms of the support that schools are providing, how much of that is due to competing priorities, right? Because there's limited resources, there may be only one student in the school who has SED. And so maybe people's attention are on more comments.
Yeah, so it is true that there are a lot of competing interests in trying to support the kids, and things like challenges with mental health are more common. It's also a comorbidity for sickle cell. So what we've been trying to do is tap into just the partnerships in general so that the school nurses and the staff know that we're here. We can't make a big push to focus just on sickle cell. So what we try to offer is like a whole package of education and services. So our quality improvement project right now is focused on mental health screening. So right now we're doubling up on that, but it is a challenge. So if we were limited in resources and trying to roll things out, which we have been, we focus so far on districts that have a higher concentration of the kids with sickle cell. But for sustainability, what we're doing is designing materials that are easily accessible and free to the public, so that if we do an awareness campaign, that then if people know they have a student like this in the building, they can easily pull those things to try to help the kids, and then they can contact us if they have other questions. But we have this discussion a lot in our hospital. So kids with diabetes, kids with asthma, there are a lot of overlapping profiles here. And so, some would say we should just be sharing all these school liaison resources. But for us right now, we have the support for somebody just to focus on sickle cell. Is there anything on Zoom, Sarah?
No, it's not. Allison, you talked a lot about you being available and your team being available to the schools and feeding information that way. And when I think about that, especially in the context of SCDC and thinking about, the kids that aren't engaged in CHEAR, is there a bi-directional or the opposite direction feedback where there are kids, can the school play a role in helping kids re-engage in healthcare?
So it's only happened once. Right. I mean, so just as background, I've been at WashU my whole professional life. So most of the people in the area know that this is my thing, and they'll reach out to me and I will respond. The reason that it hasn't been as much of an issue of the schools coming to us to identify people is because our newborn screening program is so strong. So we have 2 children's hospitals in St. Louis. WashU is the St. Louis Children's, Cardinal Glennon is St. Louis Universities, and both have the newborn screening contracts. And all of our kids that are identified by newborn screening are plugged in by 3 months. And both clinics are doing a pretty good job of following the kids. I would say our program is more focused on this particular topic because it's of my interest. But we meet with the SLU team quarterly. So what's ours is theirs, because we just want to help the kids. But there was one instance of somebody who moved into state that then got referred over. So we would be happy to do that. But, it's, again, just us being out there to continually remind people, hey, we're here, we care, we'll help. So. Yes.
Wonderful talk. Thank you so much. I was wondering if you had looked at any of the impact on parents and their employment and work absenteeism, and then if there's any support available for that.
We have not. So we've done descriptive studies. When I had a study funded by Doris Duke earlier on, where we did cognitive assessments, and then we had a long profile that really was influenced by a psychologist named Gene Brody. He used to be at University of Georgia. So he helped me construct all these domains of questions to ask, anywhere from racism to depression, issues that we thought were relevant to those families. And that's where we got the data that showed that these predominantly moms, but the primary caregivers had a higher rate of depression. Qualitatively, what we hear is that it is very challenging for the primary caregiver to maintain full full-time employment because it's so unpredictable of when people are going to need to go to the hospital, and you know, you have to be at a job for so long before you get FMLA. It's very challenging. But we haven't had a large-scale study about that, but it is important because it all, you know, it's all like a circular environment. So your point is well taken. All right. Yes.
With the executive functioning deficits and attention deficits, are stimulants kind of recommended in those situations? And if it sounds like they're not prescribed if so, they're not prescribed very frequently.
Right. So they are recommended. If somebody meets the diagnostic criteria, then they should be offered the stimulant just like anybody else. I don't have the data to prove it at this point, but I think that there's some bias. When providers are approaching this and they're prioritizing, like, what do they spend their time on? It's more of like the bigger hit of like, have you had a stroke? Have you had your TCD? And hematologists don't particularly want to be the people who are prescribing the stimulant because that's a monthly prescription. And we had this discussion at dinner last night. You know, I didn't intend to be prescribing a lot of things that I'm prescribing these days, but here we are because that's what best serves the families. So part of it might be whoever the regular provider isn't necessarily considering it. In St. Louis, mostly general pediatricians are managing that. So it's required some outreach with the pediatricians to encourage that. And then some families just don't like the idea of taking another medication. So Ebony, I think, is probably doing the best work on this, and hopefully she'll be able to give us more data on what the barriers are and trying to overcome that. But kids do improve. I mean, when I started doing the PHQ-9 screening recently as part of my quality improvement, and so whenever I get a higher score on any question, I go over it with them. And twice now, when people have endorsed some concerning symptoms, what they've told me is, oh, I can't get in with the pediatrician, so I haven't had my Ritalin for 3 months. So then I just prescribe it because I'm like, well, that would be a big quality of life, you know, improvement for you. And it has. Same thing with antidepressants. So, you know, if I had all the time in the world and every provider did, I think we could provide more comprehensive care, but we need to figure out how to do this more efficiently and make sure that we're offering that.
This feels like a classic kind of siloing problem. Nutritions may not necessarily be the primary source of care, usual source of care. Neurologists may be the usual source of care, but may not want or have training.
Yes.
Dealing with general pediatric stuff. And so in the end, the patient kind of loses, right?
It's even worse in the adult setting. So most of our patients do have pediatricians for primary care because I think with state managed care, they do a pretty good job of asking all the patients to be plugged in. We make it a priority to make sure that they've identified a general pediatrician because our clinics really can't accommodate all of the visits that would happen for pure gen peds issues. But in the transition to young adulthood, despite my best efforts to get everybody an internal medicine or family practice doc, because our clinic is the only one for 18 to 26-year-olds in St. Louis. The other health system doesn't have a sickle cell program. And we're not in clinic enough to do general care. It's so many things fall off in that age group. So I think that also makes it more challenging with just the identity of an adolescent not wanting to be identified as having a chronic condition. But if I could wave a magic wand, what I would do is have a clinic where a general pediatrician and a general internist is there with me so that we could just do everything. The families would just make one trip. You know, you're missing some work, but at least you'd only do it like once every so often as opposed to having to miss multiple days.
They have that model at Children's Hospital of Michigan in Detroit where they have general pediatricians in the clinic with the hematologist there. And so I'd be curious what the proportion of stimulants might be for kids there.
Yeah, that's what I was going to ask. Are their outcomes different?
I don't know. I'd have to ask the hematologist that is in that clinic, but they are a medical home. And so that's something that they have built into their model. They've got quite a large sickle cell population in Detroit. So I think that's why they have the resources and the capacity to do something that looks like that model where, numbers across the state might look a little bit different. I could certainly ask and follow up, and I'd be curious about that. Additionally, we work with that clinic and have brought in the Medicaid health plans to also be an ally and an advocate to CHEAR through policy change of incentivizing the Medicaid health plans, because they can offer case management and community health worker support at, like, when I saw your pathway image, they can connect clinic, community, and schools through the resources that they use too. So they can, help with 504 plans and housing instability and food insecurity and all of those things. So, but it's a slow effort.
That's fantastic, though, that those managed care plans will do that. In St. Louis, often the managed care plans just defer to our team because, we're seeing people more regularly, but it would be really nice to have a community health worker. We have one, so our CBO has 2 community health workers, but they've largely focused on adults because there are fewer resources. And then our health system invested in 1 community health worker for our adult team. Okay.
Right, we're at time. Thank you, everyone. And thank you, Allison.
Thank you for having me.